Dr. Shefali, your video is off and we can't hear you either.
Okay.
Thank
Yes,
you.
can you hear me?
Yes.
Yeah. So I think we've had a wonderful talk by Dr. Rath and Dr. Kaushik Bhujani, and uh, I see a lot of scleroderma in our rheumatology clinic, and we've been conducting scleroderma awareness programs since the last couple of years. And it has been very useful for the patients because simple things and interacting between patient groups, patients are able to share their anxieties and questions. They're able to sort out their problems together. So I think it's a very important activity. And one thing I would not repeat or what has already been said, scleroderma happens in overlap with other autoimmune diseases like rheumatoid arthritis, with lupus, with myositis. So sometimes pure scleroderma is just about 50% and scleroderma overlap with rheumatoid or with vasculitis, with apla. So all other autoimmune conditions also can coexist with scleroderma. And we have seen that there are a lot of um, so this is the classification criteria, and like Dr. Rath had already said that you have localized limited systemic sclerosis and diffuse systemic sclerosis, and he's already talked about the skin score, so we will not talk about that. Also, we know that there are a lot of other systemic complications which scleroderma patients have, like the reflux, like interstitial lung disease, pulmonary arterial hypertension, the scleroderma renal crisis. So these exist. Besides that, we have a lot of inability to use the hand, whether it is due to the contractures or it's due to overlap with rheumatoid arthritis, it's tenosynovitis, calcinosis. So you can have impending gangrene and severe Raynaud's. So there are multiple other things that we can have. Besides, what's not been touched is many patients have urinary and fecal incontinence and they don't share it. They are shy sharing it with you. But it is rather common, and neuropathy is also another common complaint in our patients. So, like Dr. Rath has already said, we do the routine test, the other HRCT, PFT, echo, and the nail fold capillaroscopy, which we are regularly doing at PGI Chandigarh. So I'm just going to skip all that. And now coming to the issue of fertility, pregnancy, how do we manage a pregnancy? Do we need to be scared? And do drugs affect the chances of becoming pregnant? And what drugs to use? How difficult it is for a scleroderma patient to deliver? And whether the mother or the father will give the disease to the offspring. So these were some of the questions which I was asked to talk about. So fertility in scleroderma, difficult to determine as many issues can. The fertility in scleroderma is not affected as in limited scleroderma, there are no cases of infertility. However, in diffuse, uh, the fertility can be affected if there is the fibrosis of the genitourinary tract. So, generally, in scleroderma patients, the fertility is not affected. And what are the conditions which we need to see, which are complete contraindications to pregnancy? So if a scleroderma patient is coming to your OPD and she wants to get pregnant, so what are the conditions in which you will say, okay, you should not get pregnant? So they are, if the patient has severe pulmonary arterial hypertension, severe restrictive lung disease, advanced renal failure, or cardiac involvement. they are the conditions in which you tell the patient, okay, it's better that you don't get pregnant. Because of the complications, the mother is going to suffer. So your rheumatologist will decide whether you can proceed with getting pregnant or not. However, what is the good thing is that normally all our patients who are coming or are getting diagnosed are usually in their 30s. And in India, family, usually they've already completed family by the time they get diagnosed. So that is one good part, that they have kids early on, and generally they have completed family by the time they get diagnosed with scleroderma. It's unlike lupus. Lupus patients come to us in their teens. So somehow scleroderma patients are generally a little older by the time they get the disease and they get diagnosed with the disease. So how pregnancy affects scleroderma? So in general, there is no exacerbation of scleroderma during pregnancy. In one large study, which was done by Virginia Steen, uh, they saw that almost in 99 pregnant patients of scleroderma, only 4 deteriorated, and all of them were anti-HCl70 positive. Now, certain symptoms like Raynaud's improved during pregnancy. However, there is an increased risk of renal crisis, and if a patient has scleroderma renal crisis prior to being getting pregnant, it may lead to adverse maternal outcomes. Also, the gastroesophageal reflux worsens during pregnancy as expected. Now, how scleroderma affects the pregnancy? So, Virginia Steen is one of the leading rheumatologists in the US, and she has a lot of work on scleroderma. So, she has documented that the miscarriages in scleroderma pregnant patients were to the tune of 9%, which was to the tune of 7.5% in healthy controls. So, not really something to get worried about. And if the blood pressure during pregnancy is not controlled by the non-ACE inhibitor drugs, then an ACE inhibitor can also be added. But in that case, the patient will need to be monitored for the side effects that it can cause. Also, besides this, scleroderma pregnancy has a higher chance of miscarriage, prematurity, and rarely, very rarely, infant mortality. But we do see a lot of scleroderma patients getting pregnant and delivering successfully. So, not so much of an issue like in rheumatoid patients getting pregnant. Scleroderma doesn't really flare up during the pregnancy. So, what are the concerns in a pregnant scleroderma patient? So, they are generally renal, whether your renal parameters will worsen, your ILD will worsen, pulmonary arterial hypertension, any cardiac issues, do you have any associated conditions like antiphospholipid syndrome? So, whether these are the concerns, but we need to understand that every patient doesn't have all the diseases. Some might have renal involvement, some might have interstitial lung disease, others might have only skin. So depending upon the person, we really need to tailor the treatment and to treat the person. So when should you plan the pregnancy? You should plan the pregnancy when the disease is in remission. So that is a golden rule. We do it in all patients, whether it is rheumatoid, whether it is lupus, whether it is scleroderma. We always tell the lady to plan the child when your disease is not active. However, in India, we never see this. So the patient just comes in the OPD and tells us that I'm pregnant. And sometimes we just have to see, okay, which drug she was taking, and then everything happens in a very erratic manner, but that is actually what is actually happening in the OPDs. So what are the side effects which the treatment will have on the pregnancy? So normally these patients are on glucocorticoids, even low dose. So there is an increased risk of hypertension, diabetes, puerperal sepsis. So, and normally if the patient is pregnant, we generally uh, just give hydroxychloroquine, which is safe during pregnancy, and that can be continued even during the lactation. So, but what is important here is that all the drugs which are being given are either immunosuppressives or immunomodulatories. So they kind of predispose the patient to sepsis, infection, the disease per se also. So that is the thing which we need to be careful during the pregnancy and during delivery. So, depending upon what disease the person has, whether it is ILD or it's the renal involvement or it's the cardiac involvement, a multidisciplinary approach is important. And from the beginning, you need to involve the gynecologist. In fact, that is the most important, that all the high risk deliveries should take place in the hospital, and you should be available to monitor the patient during the delivery and afterwards to start drugs, whatever are required, depending upon the patient. So during delivery of scleroderma patient, it is tricky because it is an anesthetic challenge, because the thick skin causes difficulty in getting a venous access. Also, there is vaginal constriction, taut abdominal wall makes position, the maintaining the position difficult during delivery. Also, general anesthesia is avoided in these patients as they have microstomia. So the best bet is a regional anesthesia like an epidural block. So that is the most preferred form of anesthesia for these patients. For lactation, we generally, depending, as I already said, depending upon what exactly organ is involved, the same therapy can be given, whether it is hydroxychloroquine or sulfasalazine or dolo. So anything, whatever the patient requires and whatever is permitted during lactation, we allow it. If the patient is on low dose steroids, it is advised that there is around 4 hours gap between feeding the child and taking the steroid, so that there is minimal side effect on the child. So, but breastfeeding is not contraindicated. The mother can continue to feed the child. So we never tell the mother not to feel unless and until we are pressed against the wall to give some drug in which she has to quit lactating the child. So coming to this question as to whether the patient will feel whether my child will inherit this disease or not. So this haunts most of the patients. But let me reassure you that we have around 800 patients on follow-up. It may be actually more, and only 8 patients have families which have more than 2 scleroderma patients in a family. So we decided to do the HLA typing in these patients. Actually, we've done it in 150 patients, and we have found that there are some HLA associations. I will just not go through all this. Uh, uh, there are different alleles for the diffuse and the limited. And what we found is that HLA 24, 32, and 35 and DRB1 11 were the susceptible alleles associated with the North Indian scleroderma patients, whereas the HLA 68, DRB1 10, and DRB1 12 were the protective alleles for scleroderma. So there is some genetic basis. However, there are many patients who have the genes, but in the same family, but do not have the disease. So there are some environmental triggers as well. So I don't advise any one of you to undergo these tests because they are more for research purposes. But whatever said and done, very few patients will pass on the disease to their children. So I think we really, what is different with scleroderma is that the skin is involved. So cosmetically, it is apparent, but not all patients progress rapidly. Not all patients deteriorate. Sometimes the patients deteriorate, but they do stabilize. So let's not lose hope and let scleroderma not take away your smile. And thank you.